moderator for today's session. Now it is my pleasure to introduce our presenter, Dr. Valérie Marchand. Dr. Marchand is a gastroenterologist in the Division of Pediatric Gastroenterology at Saint-Justin Hospital in Montreal, Quebec, Canada. Dr. Marchand completed her Pediatric Gastroenterology Fellowship at Saint-Justin and then completed a Nutrition Fellowship at the Medical University of South Carolina. Dr. Marchand has been taking care of the neurologically impaired child as one of her interest areas. She is Professor of Pediatrics with the University of Montreal and has been the chair of the Nutrition Committee of the Canadian Pediatric Society from 2006 to 2012. She has published articles, abstracts, posters, and book chapters on various nutrition topics and has lectured at various national congresses. Today, this webinar will review how to evaluate the nutritional needs of children with neurological impairment and how nutritional support can be delivered effectively to achieve nutritional goals through a team approach. I will now turn the floor over to you, Dr. Marchand.
Well, thank you, Michelle. It is my pleasure to be able to discuss with you a topic that is very dear to my heart, which is nutrition support in the neurologically impaired population. So let's start. And what I would like to do today is to help you understand the importance of nutrition in this population, to be able to evaluate their nutritional needs, to be able to provide them with adequate nutrition support, but also to detect and treat the problems that may interfere with adequate nutrition in this particular population. What I would also like to do is to help you consider the quality of life aspect and also the need for a multidisciplinary approach in that patient population. So those are the numerous gastrointestinal and nutritional issues in that patient population, and we will try to go through all of them in this talk. So for a long time, malnutrition has been a given in children with neurological impairment. And although malnutrition affects a large proportion of those children, it should not be considered part of the disease. We know that all markers of nutritional status are affected. Most of the time they are underweight, but in about 10% of this population, they can also be overweight. Since the life expectancy of neurologically impaired children has improved, the consequences of malnutrition are even greater, and we need to take nutrition into account when taking care of these patients. So most of the time those patients are undernourished, and undernutrition affects quality of life and well-being greatly. It increases healthcare use, they are hospitalized more often, it impairs their participation in various activities. So we need to improve their nutritional status in order to improve their quality of life and health. When we improve nutritional status, a lot of times we improve gross motor abilities. Children who are better nourished have less irritability and sometimes are even less spastic. They will heal better. And they will have a better strength, particularly in the respiratory muscles. This will allow them to cough more effectively and may reduce the number of respiratory infections, which is a problem in that patient population. So a lot of factors will affect growth. Some of them are non-nutritional. There's genetic background that is important to consider. The neurological disease also, independently of nutrition, will affect growth, and we've all seen patients with spastic hemiplegia that are significantly smaller on the affected side. So growth in this population is affected even in the absence of malnutrition, and correction of malnutrition does not correct statural growth completely, and height z-score will decrease with age independently of weight z-score. But besides those factors, there are nutritional factors that are we can have an impact on. Caloric intake is lower in this population than in controls. If the patients are able to self-feed, they may lack the speed and the coordination to be able to feed efficiently. If they depend on a caregiver, they may not be able to communicate hunger in society. So they have a significant reduction of oral intake because of their slow rate of feeding and prolonged feeding time, also spillage of food. But they also have altered metabolism. We know that resting energy expenditure is lower than in controls, normal controls. But we also need to look at total energy expenditure, which is affected by many factors that we will discuss a little later. One of the very important factors to consider in this is the swallowing dysfunction, because swallowing dysfunction is a major contributor of malnutrition. Swallowing dysfunction is very common. Up to 90% of patients with cerebral palsy have some degree of swallowing dysfunction, and they often require non-oral feeds. Oral dysfunction, oromotor dysfunction is a major contributor to malnutrition, and we know that affected patients are more malnourished. They have lower weight for height, and because prolonged meal time does not compensate for their inefficiency. So oromotor dysfunction can manifest as inadequate suction, dysfunctional swallowing. They often have persistent extrusion reflex, which can affect oral feeds, inadequate lip closure resulting in spillage, and they have reduced ability to chew, and we need to modify the diet oftentimes. What is the expected growth in patients with cerebral palsy? So the first set of growth charts for cerebral palsy have been published in '96 by Crick, and they were based on a rather small number of patients. But what they showed is what we can see on this slide. The darker lines are the patients with cerebral palsy, and the lighter lines are normal children, and you see that weight and height is lower in patients with cerebral palsy. The second set of growth charts have been published a little later in 2007, and they were on a larger number of patients. They were divided in 5 levels of functional ability. So a growth chart was available for each level of functional ability. And what we can see is that in all levels of functional ability, the weight was lower in the patients with cerebral palsy than in normal children, and the more severe the disease, the more severe was the growth failure. So it was seen in weight, and it was also seen in height, and it was also seen in the BMI. The latest set of growth charts was published in 2011, was based again on a large number of patients according to 5 levels of functional ability. The group 5 was divided in 2, those who were able to self-feed and those who were tube-fed. This is a very interesting growth chart because you have this is the level 5, tube-fed and non-tube-fed, and you can see there's a shaded area that shows you the group of patients that are at increased risk of mortality and morbidity. So those charts are interesting and they're available. I just put the link on the slide. However, the CDC has stated that the use of special charts to assess growth in children who have conditions with no genetic or chromosomal basis for altered growth pattern, and that is patients with cerebral palsy, is not recommended. Why? Because those growth charts only describe how a group of patients with CP did grow and maybe not how they should grow. It can normalize malnutrition. But it may give you an idea of the range of growth that is expected in children with cerebral palsy. However, growth on a lower percentile on a CP growth chart should raise concern. So how do we assess those patients? We'll go through the different elements of nutritional evaluation. So the first thing is to perform a good medical history. You should also look at the severity of the disease. What is the level of functioning? What is the muscle tone? Is there involuntary movement? You should also look at all the GI symptoms, gastroesophageal reflux. Also symptoms suggesting pulmonary aspiration. You can have chronic cough, you can have recurrent pneumonia, you can have choking when feeding. You can have those gurgly sounds when the child is eating. You should have also look at signs of poor immune function, recurrent infections, pressure sores. You should look at fractures. Is there a history of fracture? Fractures are very common in that patient population. You should look at medication, especially muscle relaxants, because a lot of times when a child is very spastic and is started on a baclofen pump or on baclofen, their caloric needs decrease and they often gain weight very rapidly after. Seizure meds can affect metabolism of vitamin D, leading to osteoporosis, so you need to consider that also. And of course, growth history is very important, and all available measurements should be put on a growth chart. When you evaluate a child with cerebral palsy, I think the nutritional history is very, very important. You should look at the type and amount of food ingested, and oftentimes the 72-hour food record is useful. You should also look at the degree of dependency on a caregiver, if the child is able to self-feed or if he depends on a caregiver. And if so, is it always the parents who need to feed the child, or is there anyone else who is able to feed the child? And oftentimes the parents are the only one that are able to feed their child. What is the duration of the meal? A meal shouldn't last more than 30 minutes. Are there signs of oromotor dysfunction, just like we just discussed? Is there symptoms of aspiration? What is the stress level associated with meal? And what is the degree of fatigue of the patient, but also fatigue of the parent at the end of the meal? Has there been periods of dehydration where feeding were insufficient? So all of this should be looked at. But a lot of times what I like to do is observe a parent feeding the child, because oftentimes, and it's been proven, that caregivers will overestimate caloric intake, and they will also overestimate the time they spend feeding their child. So observation of a meal can be very useful. So what you want to do is assess if feeding is adequate, if it's safe, if it's efficient, but also if it's enjoyable. So those are the questions that you should be able to answer. Is the child able to feed safely? How long and how frequent are the meals? Do they have to feed them 8 times a day? Does the food need to be modified? Is there any thickening agent? Do we need to puree the food? Do we need to increase the caloric density of the food? Has there been any intervention? Have supplements been used? Has the child been tube fed on occasion? And if so, was it successful? Is mealtime stressful? Have there been episodes of dehydration? And are the parents concerned about growth and about feeding? So once you've performed a good nutritional history, then you need to move on to the physical examination. And of course, you will do anthropometrics, and we will discuss that a little later. But also assess for the presence of contractures. What is the muscle tone? Is there involuntary movements? Because some patients with cerebral palsy will have those choreoathetoid forms where they move all the time. Is there a scoliosis, which may be important when you consider putting a gastrostomy in? Oral health is very important. A lot of times they have cavities, if they have gingival hyperplasia from the use of seizure meds, and that can affect their oral intake. You need to listen at the lungs, to the lungs, because to look for signs of aspiration. Look also for signs of constipation. Look for pressure sores, edema that can be suggestive of hypoalbuminemia, and digital clubbing that can be suggestive of chronic lung disease from aspiration. So in terms of anthropometrics, it is often a challenge, especially length, which is a challenge because of the presence of contractures and scoliosis. So you may need to use segmental measurements. Those are, as shown here, upper arm length, tibial length, and also knee heel length. And those measurements can be put on charts designed for cerebral palsy, and I put the charts right here, and you have the reference also. They can also be used in formulas that can be used for estimation of statures from those segmental measures, and I've put those formulas here for you. Other anthropometric measurements, such as arm circumference, may help to assess for muscle mass. Tricep skin fold can be used, but they are usually not a good indicator of fat stores because patients with CP tend to have abnormal fat distribution with truncal retention. So subscapular skin fold may be a little more useful. In terms of blood work, I don't usually do a lot of blood work because most of the time it doesn't change my management, and most of the time it is normal. So CBC can be used to detect anemia. Prealbumin and albumin are usually normal in that patient population, even when they're severely malnourished. Electrolytes are usually normal as well. What I do is assess bone health with vitamin D levels, but also bone densitometry. I usually do a bone densitometry at least as a baseline and follow thereafter according to the results. GI investigation. It's useful, especially when you consider putting a gastrostomy in or when there are GI symptoms. An upper GI series can be used to detect anatomical abnormality, and what I usually find is in patients who have severe scoliosis and severe malnutrition or patients who have lost a lot of weight, I will see a superior mesenteric artery syndrome where there is an obstruction of the duodenum, and that can lead to vomiting, and they often require jejunal feeds. Swallowing studies, if you consider that there might be swallowing dysfunction. And a 22-hour and 24-hour pH probe and gastric emptying scan are useful when considering a gastrostomy to see if you need to perform an anti-reflux procedure as well. So that's basically the investigation that I do to be able to better intervene in this patient population. So now we're going to move on to nutritional intervention. And in order to do so, I would like you to answer a quick question on a clinical case. So you have this 12-year-old boy with spastic quadriplegia, seizure disorder, he's on seizure meds, is fed orally, has occasionally required NG tube when he had a pneumonia or when he had a gastroenteritis. The meals at home last about an hour. It's 4 times a day. Despite all those efforts, he has poor growth and he's currently admitted for fracture of the femur. The parents and the sibling are exhausted. So what would you do with this patient? So I'll give you 30 seconds to put all the answers that you want to put in. Okay. So do we see the results? So for those of you who answered A and B, I think this would be an interesting idea, but the meals last already about an hour, and it's 4 times a day, and it's not working, and everybody's exhausted. So I think this has probably been done and will not work. So for those of you who answered C, which is initiating nasogastric feeds, that's probably what I would do. And for those of you who were very willing and decided to insert a gastrostomy, well, it's probably going to happen at some point, but I usually try nasogastric feeds to start with. In terms of nutritional intervention, a multidisciplinary team should be involved, and this team consists of physicians, nutritionists, nurses, speech therapists, and OT, physiotherapists, and sometimes you need psychologists and social worker, and all of this should be family-centered. So the first thing you need to do is to determine energy needs, and you know that it is often difficult. Energy needs are as low as 60 to 70% of the needs of a normal child, and most methods that are used to estimate energy requirements will overestimate energy needs in this population. So it needs to be individualized and account for multiple factors that you will see on the next slide. And indirect calorimetry may help. It's often difficult to perform, and I think that the best way to ensure that adequate intake is being given to the patient is to monitor the response to nutritional intervention. So I've put here this nice formula by Crick, which is maybe difficult to calculate, but can be used as a starting point to estimate caloric needs, and can be modified according to response. So what I find interesting in that formula is that it accounts for muscle tone factors. So you will increase the caloric needs if the patient is hypertonic, and decrease if it has severe hypotonia. It accounts for activity factor. We know that a child who is able to walk and who has cerebral palsy, the energy of walking in this patient will be higher than the energy required for walking in a normal child. And you may also add growth factor. So I think it's an interesting formula that can be adapted and just give you an idea of the factors that need to be considered when determining energy needs. Then you need to set a goal, and you need to set like what you want in terms of weight gain and what is the time frame. You want to avoid rapid weight gain, and you also want to avoid excessive weight gain. You have to be careful because you don't want that child to become obese, because it will affect their functional abilities. So you want to avoid excessive weight gain. What you want is for a less than 3-year-old or a patient with normal activity level, you should aim for the 50th percentile weight for height. However, in a patient who's wheelchair bound, 25th percentile is probably sufficient. And for a patient who's bedridden, the 10th percentile weight for height is usually adequate. So what you want to do is to, if the patient can safely eat by mouth, you want to improve oral intake. And with the help of an occupational therapist, you can improve positioning, you can provide adequate equipment, you can also improve oral motor skills. With the nutritionist, you can adjust the food consistency, the fluid thickness, you can increase the caloric density of food, provide oral supplements, and to be able to have optimal oral intake. However, if oral intake is not sufficient, then you need to move on to enteral nutrition. So for sure, if oral intake is unsafe because of swallowing dysfunction or recurrent pulmonary aspiration, you need to move on to tube feeds. If the meals last more than 30 minutes, some parents will spend up to 6 hours feeding a child. So in that setting, enteral nutrition is indicated. Also, if the child is very difficult to feed and if the stress associated with mealtime is unbearable, then enteral nutrition may help. However, you need to discuss this carefully with the parents, because it is often a very difficult decision for them to move on to enteral nutrition. Once you've discussed enteral nutrition, then you need to discuss what will be the route for administration of feeds. It can either be nasogastric, it can either be a gastrostomy. So nasogastric feeds should be used for short term or as a trial to assess tolerance before moving on to a gastrostomy. The gastrostomy is more invasive, but also much more convenient. It can be done endoscopically or radiologically. It's a percutaneous technique that takes about 10 minutes to perform, or it can be done surgically. I usually keep the surgical option for the patients who I cannot access their stomach percutaneously, or in patients who need an anti-reflux procedure. In some patients, you may need to resort to post-pyloric feeds, but those are not very practical. So once you've decided what is the route of administration, then you have to choose the formula. Usually in patients less than a year, an infant formula would be adequate. You can concentrate. You can add modular nutrients, but whenever you do that, you need the help of a nutritionist because you want the final product to be nutritionally adequate and safe. Over the age of 1, usually you use a pediatric 1 cal per ml formula. Oftentimes you need to add fiber or to use a formula that contains fiber. In some patients with high caloric needs or feeding intolerance, you can use a 1.5 cals per ml formula. In those patients who have very low metabolic rate and who tend to gain weight very rapidly, you should use, if available, a 0.75 cal per ml formula to ensure that the micronutrient intake will be adequate even if they have very low energy needs. In some selected cases, you may want to use semi-elemental or an elemental formula, which helps with gastric emptying. You should avoid adult formula because of inadequate calorie to nutrient ratio. I usually keep them as long as possible on pediatric formula. Nowadays, a lot of parents will ask you about pureed food, which can be used, but always with the help of a nutritionist to ensure that the intake is adequate in terms of calories and micronutrients. The feeds can be administered in a continuous way or in boluses. Oftentimes what you need to do is a combination of both when patients with high caloric needs or with feeding intolerance. So you use boluses during the day and nighttime feeds. You need to be flexible in the administration of feeds, and the best schedule is the schedule that will fit the family life. So it depends on the child schedule, what are their needs, what is the tolerance, also with the type of enteral access. And what I sometimes do is I give the parents an amount of formula that needs to be given throughout the day, and they decide when they give it and how they give it. And the end point is the total amount that I gave them. The nutritional requirement in neurologically impaired patients, there's no clear guideline. So you need to follow the guidelines for micronutrient intake in a normal child. But in neurologically impaired patients, you need to ensure that they have adequate fluid intake and also sodium intake. You need to provide fiber. And those patients with very low energy requirement may require vitamin or mineral supplementation, especially vitamin D. So in terms of special consideration, you need to discuss with the parents the gastrostomy, and I've put the gastrostomy because parents are often very reluctant to have their child go through a gastrostomy. Eating is a very emotional thing. The parent's job is to feed their child, and eating is a very social thing also. So they often perceive the gastrostomy as their failure to feed their child. It's unnatural, and they're afraid their child will lose the oral satisfaction associated with eating. But I have to tell you that most of the time, the parents are very happy afterwards, and sometimes they tell me I should have done that before, because it decreases the stress associated with meals, and it makes mealtime a little more enjoyable. In any rate, the decision to have a gastrostomy should be discussed thoroughly with the family and the patients. And they will have the gastrostomy when they're ready. I never impose a gastrostomy. I always propose a gastrostomy, given that the child can eat safely and can eat enough. And sometimes it takes months, sometimes it takes years, but you have to be patient, and the parents will eventually make their decision. But you need to talk to them about the gastrostomy to try to demystify what the J-tube is. A lot of times after the gastrostomy, the patients are much better in terms of respiratory problems, and they will catch up with their growth some, and they are most likely to have an adequate weight for height after a gastrostomy. Just try to avoid overfeeding those children and make them obese. So we'll move on to case number 2. Which is a 10-year-old girl with cerebral palsy. She has poor growth, and there was no evidence of GE reflux. So you go on to put a gastrostomy in her, and after the percutaneous gastrostomy, she develops a GE reflux. So what would you do? So for those of you who decrease the volume of feeds and increase the caloric density of feeds, you're right. For those of you who decided to initiate an anti-reflux treatment, you're right, but I would do that after modifying the diet. And for those of you who performed an anti-reflux procedure, you may be right in the long run. Maybe this child will require an anti-reflux procedure, but given the rate of complications in neurologically impaired patients who have an anti-reflux procedure, I would start with conservative measures. Gastroesophageal reflux is very frequent in neurologically impaired children, and a lot of times it worsens after you initiate tube feedings. Why? Because you go from mostly pureed diet, usually in small amounts, and you give them a larger volume of food, and it's also liquid, it's also formula. So because of that, you sometimes reveal a reflux that was present before, but was not clearly evident clinically. So initially, what you should do is conservative measurements, like adjusting volume and consistency, modifying the feeding schedule, and then you can move on to medication, and if required, if necessary, you go on through to a Nissen anti-reflux procedure. Aspiration pneumonia is also a problem in that patient population. The aspiration may come from saliva or food if the patient has swallowing dysfunction, or gastric content if the patient has GE reflux. And the two entities are often difficult to differentiate. So a salivagram, a pH probe, or a gastric emptying scan may help you differentiate those two entities. But you have to remember also that pneumonia in this patient population is not always from aspiration. Another special consideration, and I'll finish with that, is osteoporosis. Osteoporosis is very common in patients with cerebral palsy because they don't bear weight. They're often not exposed to sun as much as other children. Calcium and vitamin D intake are often insufficient, and also they use anticonvulsants that may interfere with the metabolism of vitamin D. So I think osteoporosis osteoporosis is a very important thing to look for in patients with cerebral palsy, because you want to avoid those fractures that can happen just by changing the diaper and can greatly affect their quality of life. So just do bone density and look for osteoporosis. So I hope this was an overview of nutrition in neurologically impaired patients, and I hope I was able to convince you that nutrition is an essential part of the treatment for those little patients. A multidisciplinary approach is preferred. They're complicated patients. There's a lot of issues to consider. But mostly that the family and the patient's quality of life must be taken into account, and the parents are very important players in that that setting. So that was it. I just put those references that may be useful for you, and I will now answer any questions you may have. Thank you.
Thank you, Dr. Marchand. As we noted, we're now going to begin answering the questions that have been submitted during today's presentation. As a reminder to all participants, you can still submit questions with the remaining 5 to 7 minutes through the questions pane in your attendee control panel. So the first question we have here is there also a chart or formulas for adults with CP? We have a few adult patients with CP, and it's difficult to know their energy requirements as well as their healthy weight, as they don't grow the same way as regular patients.
So I didn't get the question properly.
So basically they're asking, are there similar charts and formulas for adults with CP, so energy formulas I think they're meaning, for calculating energy requirements. They just have certain patients in their population that have aged out of the pediatric system and are now adults, and they're not sure what to use as comparisons based on growth and adult.
Mm-hmm. Well, and the CRIC formula can be used to assess their requirements, but hopefully when they're transferred to adult care, their growth is basically finished, and what you want is to maintain a healthy weight for them. Hopefully all the work has been done in pediatrics, and you just need to follow with the same regimen.
Great. Okay.
But what you need to, you still need to make sure that calcium and vitamin D intakes are sufficient, because they're at risk for osteoporosis.
Okay, good. Thank you. The next question is, can we use the formulas and chart discussed for all neurologically impaired children, or just for those with cerebral palsy?
Well, if any patient with brain damage can be put on those charts, the patients with chromosomal abnormalities or malformations probably will not be well represented with those charts. And it also depends when the insult happened. Those charts are patients who are neurologically impaired from birth. So if you have a neurologically impaired patient who had a car accident and brain trauma at the age of 14, you want to maintain their nutritional status, and they may not be well represented on those charts. And again, those charts are just guidelines. I personally don't use those growth charts, because they give you sometimes a false sense of security. So I usually use the normal WHO growth charts and make sure that that they follow their own curve.
Okay, great. The next question is, given that pediatric and adult enteral formulas are very low in sodium, what are your strategies for meeting the sodium needs of the fully enterally fed patient?
That's an excellent question. There's been publications that show that a lot of times sodium intake is insufficient in that patient population. and it will not be reflected in blood electrolytes. So what I tend to do is, and I do it more and more, is I tend to do urinary sodium and adjust their sodium intake by providing supplements if the urinary sodium is too low.
Okay, great. Next question. Can you please explain how to calculate body surface area as part of the Crick method for estimating BMR?
I can provide you with the reference. I have the reference at home. There are tables, and I can send the reference to you, Michelle, so you can distribute to the participants.
Okay, great. Okay. Next question here is, for a child managed mostly through a local community hospital, would a gastric emptying scan be available, or would this occur when visiting the PEDS referral center?
Most of the time in nuclear medicine, they are able to perform a gastric emptying scan if you have nuclear medicine. The problem is sometimes to have the pediatric normals. So you have to talk to the physician in nuclear medicine and see if they are able to do it, and if they have the pediatric data, but it's probably available in all community hospitals where there is nuclear medicine.
Okay, good. We have another question. What could be added to thickened tube feeding formula without causing an obstruction to the gastrostomy tube?
It's very rare that a gastrostomy tube would get obstructed. I use the thicken it or thicket, and it's mainly a problem when you use a nasogastric tube that is very smaller in caliber, or it occurs when you use nasojejunal feeds because the nasojejunal tube is smaller. But with the gastrostomy that is usually at least 12 French, there is no problems with obstruction with the thicket. You may run into problems if you thicken the feeds with baby cereals or things like that, but with the usual thickeners, you don't have any problems usually.
Okay, and I think we have time for one last question here. This question asks, how does the dietitian assess length in your clinic? I am aware of all the methods you reviewed.
Yeah, well, in order to do those anthropometric measurements, you need an anthropometer, which is not available everywhere. And frankly, in most clinics, length, and even in my clinic, length is a problem. So it's often very deficient in terms of measurements, I must say. Ideally, you should use segmental length.
Great. Well, we are out of time, so I'd like to thank Dr. Marchand and thank everyone for attending today's webinar. One last reminder to the audience, to download the handouts, use the control panel to the right of your screen. You will receive a short survey, and we would appreciate your feedback. You'll also receive a follow-up email within the next week with a link to view a recording of today's webinar and to receive your certificate of attendance. On behalf of Nestle Health Science and our presenter, thank you for joining us today, and have a great rest of the day.
Thank you.